overlap, I think. I think this point will be clarified when we...
Dr. Apul, I think you put off your video and speak. You put off your video.
Okay.
Dr. Chandramohan, can you hear him?
Yes,
Is it
sir.
only my
Not clearly, sir. Not clearly. Yesterday also we had the problem of...
I'm not sure. Yesterday also there was a problem. Okay. Am I audible now?
Yes, go ahead.
Dr. Chandra?
Yes, sir.
Am I audible now?
Yes, sir, but it is breaking. So what the connectivity is not good. Intermittent is still breaking. Still.
Okay. So now I have come outside actually. So my signal seems to be fine. Okay, doesn't matter. It's Dr. Xavier who has to do the most of the talking today.
Anyway, you ask your question, Dr. Apul. Now I think your audio is better. Your audio is slightly better now. Go ahead.
So yesterday, what I said was that whenever in a cross-sectional study also, we have a control group and a case group, a study group and a control group, it starts looking like a case control study. That we'll be discussing today. So what I'm saying is probably once we listen today's presentation, things will be clearer.
Yeah, absolutely. It'll be clearer. So we always have to define our population. So yesterday's example of prostate cancer that I gave, so the group of people are elderly men. We want to determine whether or what proportion have prostate cancer, and those, so there'll be a group of people, let us say, for simplicity, let us say 10% of those high risk men have prostate cancer. The other people don't have prostate cancer, and in both of them, you go and look at what risk factors have caused, possibly associated with the cancer. So, and today you're right. Today there'll be a lot more clarity on the difference between a cross-sectional study and a case control study. So we'll do that. Anyway, we are 4 minutes into our time now. So Dr. Chandra, over to you. You volunteered to summarize today. So we'll be happy to hear from you. And maybe Dr. Apul could give some opening remarks and Dr. Arun Chawla could say a few words and then we can get started. Yeah, please, Dr. Chandra.
Okay, sir. Should I continue? Should I start, sir?
Yes, please go ahead.
Sir, I have made summary and maybe around 3 minutes time I require to finish.
Yes, please go ahead. Please go ahead. So can rest of you all have your videos on, please? I keep asking every time. Have your videos on. Be prepared. Be well prepared for the session. That see, like, I mean, the ideal situation is our secretary today, Dr. Chandramohan. He is comfortable in his chair, well lit, nice background, and his thing. So yeah, he has set the standards for all of us, and I'm trying to catch up. And Satyanarayana, you have special prize for you. You always come on first. And yeah, rest of you all, come on. And please name yourselves. There is a number here, 574. Then there is a HP here. Yeah, rest of you all, please have your videos on. Why? I mean, are these urology people very shy or what? What, Dr. Arun Chawla? I mean, last time we were much better. We had 95% of people having their videos on and we had a more lively discussion. Dr. Rahul Kumar, welcome.
Okay, sir, with your permission,
please go ahead.
I understood maybe around 75%. I have to read it again and again. Coming to the good evening, one and all. I first of all thank Xavier sir and Apul sir and Dr. Arun Chawla sir for giving this chance for the ASU to understand the statistics. For anything, first introduction was based on the research design, biostatistics, and research management. And the next day we started some components of the research questions, the objective, hypothesis. So part of the research question he mentioned is the PICOT. It was good. We have to understand the population interested in which comparison, outcome, and time. There are various issues he addressed is burden, cause, and diagnosis. And the source of questions is not understood that either patients will be there, papers, conferences, students. They explained in templates, in the templates for cause, everywhere you have population, you have interest, and then you have comparison. He has explained template for diagnosis also. Same like patient, comparison, intervention, outcome for the diagnosis. Same like template for therapy in which you will intervene and you will get the outcome. Template for prognosis, again comparison and outcome. But after that, we moved primarily the objectives, primary and secondary objectives. Ultimately, an important dialogue that we will evaluate in the science of humanity, but not the only PPPs. So we derive some conclusion, whatever we are getting treatment today is because of the research done 100 years back. So from the question to hypothesis, then he discussed research study designs, quantitative and qualitative. Similarly, there's even a beautiful table, even though it is very big table. In the next table, he said that what I understood is if you have anything experimental study, you wanted to experiment, and that if you do randomized control fashion or non-randomized control fashion. This has highest value when you do randomize, when you are experimenting something, want to derive something. But when you want to do observational studies, I thought yesterday when he was telling observation studies are very weak. Later on, I realized that they also have their own role. In this, it is understood that whatever you observe at one point of time will become the cross-sectional study. When you follow prospectively, it will become cohort study. When you follow retrospectively, it becomes case control study, which has less value because bias can be there. That ultimately chart has come very well, where there are only 5 things: randomized control trial, non-randomized control trial, both are experimental studies. When it comes to the observational studies, it is cohort study, case control study, cross-sectional study. Up to this point, I was following well. After that, I got little confused. When he said that he concentrated on cross-sectional, it can give prevalence of a disease or it can give a cause of a disease. But that also needs time. You may need 1 month. He said that he put 6 months of efforts in his study, studying various interventions in the cardiology leading to the outcomes in different places of India as a cross-sectional study. But that also takes time. Then clinical guidelines summaries he has given. I could not understand in detail this slide of 14 questions he has kept. I could not follow that biases, how many like that. After that, I quickly came to the, again concentrated. By the time concentration was little less. Then he said that an observational design should be there in class. Obviously, it is observation. So exposure and disease status at a single point of time is the example he has given. In our MBBS also, we understood that at a given point of time in your OPD, you search that this many people, what is there, such type of observation you can give. Doesn't derive anything experimentally. Then these are single point in time, but they may take time to do the study. Some important are burden of the disease, you can understand characteristics, how they are in males, females, or old, this thing. Status of the disease in a population. Gross things you can derive from this cross-sectional study to compare them in different populations also. These are all common problems. I thought cross-sectional study of no use, but I understood when he is given 3 examples, then I could understand little better. A risk factor is estimate also you can get. These are the things he told. And ultimately he told that study population you can summarize in a clinical way that no disease, disease. And in no disease, factor present, factor not present. You take all the disease people, you see the factor, you don't see the factor. Similarly, all disease, non-disease, you see the factor, you don't see the factor. 4 will come, 4 you analyze with the various statistics. Issues in studies, he said that sampling can be, there can be problem, potential bias analysis. Sampling is representative to sample may not be representative to what you are looking for, or you have to get biased. Then potential bias defined the bias original definition. It was good. Bias should not be done actually. Bias should be avoided, but he said that various biases are there. He has nicely shown where to search in Oxford University, 256. I thought it infinity bias. Bias can be infinity, but he said 256. I could not understand how they derived 256 bias. Unless you read, we cannot understand. The overview of the study is that from the target population, you have to take the study sample and then exposed outcome present, exposed no outcome, unexposed outcome, unexposed no outcome. And then sample strategy is basically from here I could not follow much, but I am understanding. But I made my own presentation that I'm reading a little bit. Up to this level, I was correlating very well, but my concentration was less. Then sample strategy, sampling method, sampling methods, probability sampling and non-probability sampling will be there. And simple random sampling, systemic sampling, stratified sampling can be there. And clustered sampling also, I could not understand much. It was tough. Non-probability sampling methods are convenience sampling and quota sampling. Purposive snowball sampling, a little tough to understand. We have to read again because it's a 1 hour class is not enough. Bias, yes, I could understand because bias, everybody knows that. When even the good point he told that even IGO will have bias when we send this person is not good or this person institute is not good, bias can be there. There are various innate or learned biases. The systemic error he said is the science bias.
How much is the
And bias in health research, he has told. By this time, I was completely going out of my mind. Then he has given some examples, 3 examples. And those 3 examples are given some spectrum study. This was a good study. At a time, they have studied about the all the regions of India practice patterns. Then he has given other study which is related to urology, where he has mentioned a study that prevalence of diabetes and pre-diabetes in 15 states. He also mentioned one important point that when you do a cross-sectional study from that time to this time, the incidence of hypertension is increasing in rural area because they are not eating good habits or their stress may increase. Like that, it's a crude derivation from the cross-sectional study. And one more example he has given. He has quoted many papers. The prevalence of modifiable cardiac risk factors among coffee estate workers in rural South India. At a time they will take and they will analyze. Lot of analysis he has shown which I could not understand. And by the time I am exhausted, that is the summary. But overall, I understood that clearly that experimental study, observational study, randomized control, non-randomized control, case control study, a cohort study and cross-sectional study. This I got clear idea. And what is a cross-sectional study also I got clear idea. Some more depth I have to read and understand. With this, I will hand over the program to DENIS. Xavier.
Thank you, Dr. Chandramohan. Very good. You asked for 3 minutes, but you took much longer and explained so many different things. And then multiple times you said, I understood this, I did not understand that. So if you know what you have not understood, it's a good start. So in other words, there are 2 types of knowledge, they say. One is something that we know. And the other type of knowledge is the knowledge of what we don't know. We know that we don't know something. That's another type of knowledge. So very good. Thank you for that. Just one request, Dr. Chandra, as the host, can you make me the co-host? So
Yes,
you just
sir.
have to click on my
Yes,
name,
sir. Sorry,
go to more,
just 1
and
second.
then make me co-host so I
Yeah.
can share my slides and we can get started.
Done.
I see that Dr. Shivam has joined from Jaipur. Welcome, Dr.
Yes,
Shivam.
Dr. Shivam, sir, thank you once again understanding the logistics, and it is very good. It's very good that you joined. You are highly interested in these subjects. You are a good teacher in SMS. Let's hope I have shared in all the social media of mine where it is relevant for urologists, because other persons cannot do anything. At least let it be used by as many people as possible apart from South India. So you are most welcome, sir.
Thank you. Thank you very much.
Right, good. So just a quick comment before we get started. Dr. Chandra, in your summary, you said, okay, this is what I understood and this is what I did not understand. And I got tired as well, which is all very nice. And you have been very honest and forthright, which is wonderful. So these concepts take a while to understand. So as I said, and you said you understood 70%. That is fantastic. That's quite a high proportion to understand, particularly since, see, this information is not totally new to all of us. We know a little bit, but many times we are a little confused about it. If you know a little bit, sometimes first we need to unlearn before we learn. That also is a bit of a challenge. So 60-70% learning is fine. And many of these, each of these topics are 6-month courses. So we have lectures, we have statistics related to it, we have a bunch of journal clubs, then we write a proposal, and then we defend that proposal. People give comments, and then we say, okay, we have some comfortable understanding on each of these topics. But anyway, so let me now do case control designs now, and we'll, time permitting, we'll do registries as well. So this is what we are doing now on case control designs. And as always, I like to start off with a few questions for each of us to think about. Okay, and if you have no, you must have a nice notebook with you by now, and then please put a number and write a few words next to it in about 10 or 15 seconds. Don't take too long. And this is just to stimulate our mind, so that and all of these answers are coming in the next few minutes. Okay, so a few questions to get started. First, can you think of any 2 medical discoveries that were made through case control studies? If you listen carefully, yesterday I gave you one example. Maybe you can think of one more. Next, why do we do case control studies? Purpose of case control studies. And yeah, so think about it. Next, what is the meaning of association? And there's another related word, very different though, causation. Association and causation. Okay, next. Okay, we'll skip this. We'll skip this as well. Maybe we'll think about this. What is a key statistical parameter in case control studies? Next, confidence interval. We keep hearing about confidence interval all the time. We see it in our journals all the time. What is your definition of confidence interval? Write a few words. Okay, next. This is a little tricky. What is the meaning of population attributable risk? We'll skip it. And then what are the strengths and what are the weaknesses of case control designs? We're going to do that now. And now there are 3 important biases in case control designs or case control studies. Can you think of them? I wonder if any of you went to the catalog of biases in the Oxford University website that I told you yesterday. In case you looked at it, you would have seen so many different types of biases. Some of them are very exotic. We haven't heard of those names. But anyway, now what is a nested case control study? We'll look at all of this today. Okay, what are we going to do today? Purpose and definition of a case control design, when to conduct it, purpose, when, how do we select cases, and how do we select controls? Dr. Goel asked today, he said he was confused yesterday with the cross-sectional design and how does that compare? And he also said, maybe today it will become clearer what is a case control design and what is a cross-sectional design. Okay, how do we analyze and interpret case control designs, right? We look at strengths and weaknesses. biases, and as always, examples. Lots of examples we'll look at from urology as well. And I was involved in designing and conducting a global study in in strokes using a case control design, and I'll show you a beautiful study. And it had so much of powerful information coming in. And I hope looking at that example, some of you are motivated to say at least we want to do national level studies in India in urology. Okay, quickly, some important discoveries made using case control designs. In the 1950s, cigarette smoking and lung cancer, the association started with a case control design. In the 1970s, diethyl stilbestrol and vaginal adenocarcinoma in the daughters of mothers who took diethyl stilbestrol. Interesting. Postmenopausal estrogens and endometrial cancer, case control design. In the 1980s, Ray's syndrome. All of us know that aspirin is contraindicated in children for fever. So it came. This was figured out using a case control design. Tampon use and toxic shock syndrome, right? That as well. AIDS and sexual practices. I gave you this example yesterday, Kaposi sarcoma. In the 1990s, vaccine effectiveness, different types of diets and cancers. And later on in the 2000s, settling global controversies. I was involved with both these studies in Interheart in a small way, but in Interstroke, I was co-principal investigator of a large international study, and I will share those details with you. Okay, why do we do a case control study? This is important. This phrase is important to determine the strength of association of risk factors with disease. So today we're going to clarify association. Remember yesterday I told you we look at association today. The next time we will look at what is causation. Okay, we are looking at exposure and health outcomes. We want to know what is causing a particular disease, right? But with the case control design, we only look at association. So therefore, today we'll clarify what association means. Association versus causation. First thing to sort out. Association means the outcome is likely to occur with a particular exposure. There is a statistical relationship between two variables, and two variables may be associated without a causal relationship. This is tricky to understand. I'll give you, okay, let's not do medicine. Let's take an example from, let's say, from detectives or criminology. Okay, so before the days when people had mobile phones or CCTV cameras, people just had regular cameras, okay? So there was a spree of murders in the city. People were being murdered from crowded areas. So wherever people could take a picture, they took a picture and the detectives were putting it together. The police were looking at it. And then they said, in 10 murders, every murder photograph in that scene, there is one person with a red shirt. So find out that person with the red shirt. This person is the murderer. So let us say you are the judge. Satyanarayana, you are the judge. These photos are being given. Okay, they catch one fellow with the red shirt. They bring, faces match, everything. Will you send this person to the gallows? Will you send him to be hung or given capital punishment because he caused 10 murders in the city? Satya?
No, sir, no.
No?
That doesn't give a
All 10.
consideration.
Why? You feel sad for the red person, or what is the issue? Red shirt person.
No, sir, you told in 10 out of 5 he had images on the
No,
pictures.
10 out of 10. 10 out of 10.
10
I
out
didn't
of
say
10.
every single photograph.
Okay.
This person with a red, there was a photograph.
Okay.
There was an individual with a red shirt. Will you send this person to the gallows?
Yes, sir. Still, I don't think he's
You
the
will not
murderer
send.
because of just image.
Okay. Now, let us look at another scenario. By now, technology is advanced. There is CCTV cameras everywhere. Now in all our cities, everywhere, even outside our homes, inside our homes also these days, we have CCTV. Medical colleges full of CCTV cameras, isn't it? CCTV cameras are there. Now the police has video clippings. Yes, every time there's a murder, there is one person with a red shirt. Red is quite a common color. Okay. However, now they notice that another person, okay, comes pillion riding in a bike. He gets into the crowded place, he shoots a person, and then the same fellow runs to the bike and he jumps and he goes away. Okay, another scene, again you find this. So they haven't even got all the 10 videos. They got only 3 videos. In all the 3 videos, this person is there. Then they confiscate the murder weapon, the pistol or whatever he used. Okay, and ballistic say yes, the bullet matches. Will you? There are only 3. Another 7, and it is the same person in all the murders.
Okay.
Will you send this fellow? Will you give the suitable punishment for this fellow, Satya, now?
I think yes, sir. We have better evidence.
Correct. Okay, so now in the previous situation, there is a very strong association. Every time a murder happened, there is a person with a red shirt. Very strong association, but no causal relationship. So you know what they say in judiciary? There is undoubtedly or unequivocal evidence is there, and then and they go up to saying, you know, the DNA matches. You know, the murder, the blood matches, right? We go so much genetic testing up to that is done. Okay, so that is causation. All right, so association alone is not causation. Okay, right? Causation means the exposure produces the effect. The fellow in the bike, he came and he murdered, and ballistics is all there. Now, 1950s, they said smoking is associated with lung cancer. Today, is it an association or causation?
Causation.
Why is it, Dr. Chandra? Because multiple studies have shown strong association. Now, there is biological plausibility. Next time I will tell you that there are rules for causation. Okay, like we have Cox postulates, we have Hill's criteria for causation. Next time I'll tell you, next Thursday. Okay, so means that the exposure produced the effect. Okay, now it can be the presence of an adverse exposure, smoking causing cancer, or an absence of a preventive exposure. No seat belt causing worse outcomes in accidents. Not exercising causing diabetes, hypertension, heart disease, strokes, etc. All right, so that is causation. Right, association and causation. Okay, let's move on. What's a case control design? It's a method of sampling in a population. That means you identify people with a case, or these are cases, you enroll them, and this is the next step, Dr. Goel, right? You take a sample of a population that produce the same case, but is not a case. You identify from the same population another individual. We call this person a control who is not a case. And we need to conduct the same diagnostic tests to, rule out that this individual is not a case. Rule out. Okay. Then we determine exposures. For individuals in both groups, we ask them the same questions. Okay. So this is the meaning of a case control design. Once again, in simple terms, we identify a case. Let us say bladder cancer. Okay, this is a case. Okay, so this is a case. Then you find a matched. So we match for age and sex. Suppose a 70-year-old person has bladder cancer, 65 to 75-year-old male without bladder cancer. Okay, and you are
ಇಲ್ಲ ಅದು ಸರ್ಟಿಫಿಕೇಶನ್ ಮತ್ತೆ ಹೆಂಗ್ ಆಗ್ತದೆ ಸರ್ ಹಣ ಆಗಿಲ್ಲ ಅವಾಗ ಮತ್ತೆ ಆಯ್ತಾ ಮತ್ತೆ ಅದು ಫೀಸ್ ಚೇಂಜ್
mute the lines, please, for everybody.
Praveen, if you can switch off or unmute, mute your.
We are unmuting. Sorry for that. Central control is with me only. I unmuted.
Yeah, you can mute everybody now. Okay, great. Okay, so you identify a case, right? And then you and you have your diagnostic criteria for a case, and you do reasonable diagnostic tests to find a control who does not have the disease. Okay, so you can go up to whatever is reasonable. Right, you could say your ultrasound to urine test, maybe blood test, but maybe not sure you need a cystoscopy there. Okay, think about it. Okay, let's move on. Now, when to conduct a case control study? When disease has a long latent period, like cancers, cardiovascular disease. When the disease is quite rare, although there is so much of cancer and so much of cardiovascular disease, it's relatively rare. Okay. Now, when you have very rare conditions such as birth defects, you want to find out the cause for birth defects. So you go to a hospital, a tertiary care hospital, which has lots of deliveries. And recently, I was reviewing a proposal of an institution that has 12,000 deliveries every year, right? And you'll find a bunch of birth defects there. You start with the mother and the child, right? So that becomes a case for you, and then you find a control. Okay. Okay. Right. So some principles for case control designs. Exposure must be defined beforehand. Inclusion, exclusion criteria for cases. We must be clear what we are excluding from controls. We need to, I'll tell you a bit about recall bias shortly, and we need to detect those biases. Okay. And we need to manage these biases well. Right. How do we select the case? Once again, strict diagnostic criteria. Right? Let us say type 1 diabetes in children, right? Or type 2 diabetes in adults, whatever diagnostic criteria we have. Okay, we can have cases from the population, or you can, that means you can go to the community and collect cases, or you can go to the hospital and collect cases as well. Now, when you take cases, I'll come to controls. When you take cases from the hospital, you should also take controls from the same hospital, because people from the same geographic area and socioeconomic status come to the same hospital, right? Okay. Where can we get controls from? Firstly, we need to confirm that they do not have the disease, number one. Right? Where do we get controls from? We can get general population controls, very different, many different sources we can have. We can even get hospitalized controls. Patients in the same hospital, you can identify them, and it's easy to identify. They will give you consent, etc., etc. You get a high response rate as well. Okay, very rare though, but even people who are not alive, dead people, through surrogates, we can get some information or data from them. Okay, now let us look at the schema of a case control study. Okay, so we have the entire study population. In them, we identify cases, okay, and matching controls. So for each case, there is a matching control. Usually, we take one case, one control. If cases are very rare, we can take one case and two controls, and we have to statistically adjust it later on. Now, what do we do with the cases now? What do? We go backwards and ask them for any exposures. So let's take the good old example of smoking and cancer. So some of the cases will have been exposed to tobacco. Some would not be exposed to tobacco. Similarly, in the controls, some would be exposed to tobacco. Some will not be exposed to tobacco. Right? Now, if it is cancer, what do we expect? We expect this to be the highest, isn't it? Exposure to tobacco to be the highest among the cases and lesser among the controls. And I'll show you these data now. Okay, so I hope this part is clear to you, which is you identify a case, you confirm the diagnosis, and as soon as possible, you find a matching control. And in both of them, you ask similar questions. You ask them similar questions, we collect the data and we analyze. So in the next few minutes, we're going to look at what data we collect, how do we analyze and interpret them. We do the 2x2 table. Yesterday, I showed it to you in the form of a flow chart. Today, I will show it to you in the form of a 2x2 table. Okay, so we have cases and we have controls. A number of people got exposure, became a case. C number of people did not get exposed, but they still became a case. B number of people were exposed, but lucky, they did not become a case. D number of people not exposed, did not become a case. All right. So 4 scenarios we have. This is very simple. This is called a 2x2 contingency table. And one individual will fit in only into one table, one cell rather. One individual will fit into only one cell. All right. How do we analyze case control studies? Right. There are 2 possible outcomes for someone who's exposed. Somebody who's using tobacco, 2 possible outcomes. What could that be, Satya? 2 possible outcomes.
He can have a disease or he may not get a disease.
Fantastic. Brilliant. That's all. Okay. They become a case or not. They get the disease or they don't get the disease. Okay. So the odds are A divided by B. I'll show you this A, B, C, D once more. You'll understand it better. Next, 2 possible outcomes for an unexposed person. Same thing. They can become a case or not. All right. Now, odds are C divided by D. Now, the odds ratio that we're interested in is very simple. Odds of an exposed person becoming a case, A divided by B, and the whole thing divided by odds of an unexposed person becoming a case, C divided by D. Here is the, if you cross multiply, you get AD by BC. And this is the table again. Okay, once more. For an exposed person, they become a case or not. A by B. Okay, here. Not exposed person, C or D. This is the odds. Okay, and the odds ratio is this odds divided by this odds. That's all, conceptually. Okay, now don't worry about remembering these things unless you're going to write an exam in statistics and somebody is going to give you a problem. But just remember the concept. Odds, if you're exposed, not everybody who smokes tobacco gets lung cancer. Some of them get oral cancer. Some of them get bladder cancer. Some of them get liver cancer. Many of them don't get cancer. So it is odds means the probability. See, in biology, it's always probability. In physics, it is calculations. You can be exact. Physics and mathematics is an exacting science. Biology, there are so many factors, no? So that is why it is probability, and that is why biostatistics becomes important. Okay. So we are going to now analyze a case control study. Let's take that same 2x2 table. Let's put some numbers into it. Now, what do we have in our study? We have 1,000 cases and 1,000 controls. Okay, now just look at this number and one of you tell me, let us once again take the same old example of smoking and cancer. Okay, case means cancer, exposure means smoking. S over here, and this is C for cancer. Now, looking at these numbers, do you think that smoking has something to do with cancer? See, I did not use association or causation. Does it have any influence on cancer, smoking? Very simple. Just compare these two. Compare these two. Just double, isn't it? Those who smoked, okay, they had twice the chance of becoming a case. Okay. Now, let us continue on and do the odds ratio here. Do the odds ratio. Okay. Odds of exposure is 200 by 800, 0.25. Here, 100 by 900, 1 by 9, 0.11. Okay. The odds ratio is 0.25 divided by 0.11. We get 2.27. The odds ratio is 2.27. What is the meaning of this? What is the meaning of this? It means people who are exposed had a 127% increased risk of getting the disease compared to those who were never exposed. That's what it means. Where is 127 in this? Where did 127 suddenly come from? From here. Okay. In a ratio, when numerator and denominator are exactly the same, you get 1. Okay. Now the excess risk is 1.27 or 127%. Simple. All right. That is how you interpret an odds ratio. There are many more odds ratio I'm going to show you. Now this 2.27 you got, okay, with this sample size of 1,000 cases and 1,000 controls. You got an odds ratio of 2.27 with 1,000 cases and 1,000 controls. Is it this odds ratio of 2.27? Is this statistically significant? This 127% increased risk, is it statistically significant? In my first lecture on statistics a few weeks from now, I will tell you about what is the meaning of hypothesis testing and what is the meaning of significance. Okay, with numbers and with other connotations, I'll tell you. But for today, in very simple terms, is this result that we got, is it due to chance or is it real? If it is real, should I apply these findings to do something about it? So do I go to the government? Do I go to the health minister and say, we have to ban smoking? No. Don't worry. No. We get a lot of revenue from tobacco and from the cigarette industry. No. But more people are dying due to cancer. How do you know that? Here are the data. This is real finding. Okay. So that is the meaning of significance. Let's look at it. We prepare the confidence intervals. Remember, that was a question I asked you. We prepare the confidence intervals. So same numbers again, odds ratio of 2.27. Don't worry. I'm going to show you a formula. It's actually a simple formula. Don't worry about remembering it.
Sir, 1 second, sir.
Yes.
Previous slide 125% for 2.7. I did not anything related to 2.27 and 125. What exactly means by odds ratio 2.27 in that? It does derive anything, any conclusion, sir? Sorry, I did not understand.
So I'm coming to that. I'm showing you what that means just now in this slide, Dr. Chandramohan.
Okay, sir.
In this slide, I'm showing you. Okay. So is this significant? We are going to compute the confidence intervals and I'll explain that to you and you slowly, little by little, we will take it. Okay. Now we need to compute what is known as the standard error. This is the mathematical formula for standard error if you're interested. It is the square root of the reciprocals of the reciprocal means 1 by, and we add it up of all these cells. Okay. Square root of the reciprocals of the sum of each of these cells is the standard error. And the formula for a 95% confidence interval is the exponential of the logarithmic of the odds ratio plus or minus 1.96. For 95% is 1.96 into the standard error. So we get the standard error from here. We take the logarithm of this odds ratio here, here. Okay. And we add plus or minus 1.96. When we do that, we get two numbers, 1.24 and 3.89. Now, what do you notice? This odds ratio is in the middle of this. So 2.27 is the middle and these numbers are on either side. Okay. How to write this now? You will see this in all your journal articles. Okay. So this is how it came by. So I'm taking you behind the scenes in the drama. You're only seeing the front, right? I'm taking you to the green room, behind the scenes, how this was made. Okay. How to write this in your journal article, right? You write OR 2.27, 95% confidence interval, 1.24 and 3.89. Okay. So in other words, the odds ratio is the point estimate and 1.24 and 3.89 are the ends of the upper bound and the lower bound of the confidence interval. Okay. Now let me give you one more interpretation of this listen carefully. If I do this study 100 times, if I do the study 100 times, this, will I get the exact same odds ratio? Similar population. Okay, and more or less at the same time. I do it 100 times. I will not get 2.27 all 100 times. But this odds ratio, 95 out of 100 times will fall in between this. It can be 1.25 and 3.88. It can be 1.37 and 3.81. It can be 2.21 on the side and 3.17. Understood? So this odds ratio, 95 out of 100 times, will fall in between this. That is the meaning of a 95% confidence interval. Okay, good. I will skip this population attributable risk. It's a little more complex. We'll leave that definition out and we'll do strengths of case control designs, little theory, and then we'll take examples. With examples, you will understand better. Okay, it is good for rare disease, long induction, and latent periods. We can evaluate many risk factors, very important, multiple risk factors for one disease condition. In a few days, I'll tell you, cohort study is even better. A little more difficult, but even better. Good for disease about which very little is known, and you are starting off research. And my last message to you all in my last slide is, it's a good opportunity for the Urology Society in India to undertake more case control designs. It's very efficient. Weaknesses, not good for rare exposures. We have biases. Because of the retrospective nature of the study, there is recall bias. We cannot infer a temporal relationship between exposure and disease. We can't tell which one came first, disease came first or the exposure came first. We don't know. Okay, now biases in case control designs. We have selection bias. There will be some people who will not respond. Some places where we cannot detect the disease. That's called a detection bias. Okay. Then we have observation bias. Very important. I'll explain this recall bias with a good example just now. Cases are more likely to remember exposure than controls. Okay. Now we leave out cancer and we'll go into the CCU, coronary care unit. Okay. There is a 60-year-old man who is recovering after an angioplasty. Okay, he's had an anterior wall MI, massive thrombus, and angioplasty was done, and he's recovering now, and he's going to go home the next day. So you go and say, sir, we want to do a study, and we want to, ask you about your, about your life. Yes, sir, sure. I'm anyway lying down here. I'm happy to, I'm feeling good. I got a second life. Please go ahead. Okay, and please tell us when you started smoking and how much you smoked. This is a 60-year-old man. And this man says, I remember my very first cigarette. It was when I was 15 years old. It was my birthday. This rascal friend of mine, classmate, he's still there. We still go and have tea together. Still there, that rascal, he brought, when my parents were getting the cake ready in the house, we went to the back door. He jumped the compound wall and he brought one cigarette. He'll tell you the brand name of the cigarette also. Imported cigarette. His father came from Dubai. He gave me the cigarette. So he'll give you very clear, granular details. Second cigarette like this. By the time I was 20, I began to smoke one full pack. Okay, I was doing my engineering. Then I got married by age of 28, and then I had some family problems, and then I began to smoke 3 packets every day. Very granular details. Then when I was 40, I got asthma. So for 2 years, I reduced my cigarettes, but then again stress. So he'll give you very detailed data on tobacco consumption, okay, or cigarette. Now you go find a control. Control is 62-year-old man, and he is otherwise healthy. He has little arthritis and little, cataract issues, but otherwise no heart attack. The heart is all fine. So you ask him, tell me about tobacco. Yes. In my teenage, I think I kind of started smoking, maybe per year, maybe one or one. No. I think once a month I would have smoked. Not really sure. Okay. And yeah, in my 20s, I used to occasionally smoke. Then in my 30s, I became very religious. I gave up everything. Then in my 40s, on and off, I used to smoke. Then I became regular for some time. And then you saw the difference now? Who's giving you greater or clearer data? The person with the disease. Why? Is the person with the disease having better memory? No. This person has been lying down in the CCU for 3 days and recalling everything, right? So many times people told me not to smoke. Every doctor told me this. My wife told me this. My children told me this. My friends told me. Okay, so bias is something differential. Case is giving you different data. Control is giving you different data. Is it because the control is a bad person or doesn't want to help you in your study? No, that person not able to recall. So we must be able to understand this bias and we must be able to address it adequately. That's all. So in other words, you give the control little more time. No, take your time, think very patiently, collect data. That's all. So this is a very important bias in all observational studies and we need to keep this in mind. Okay, so recall bias is the full definition where recall is better among cases compared to controls. So we can have a false association between exposure and disease. That is what you'll get. You will get incorrect or wrong conclusions when there are biases. I'll skip that one. I'll skip this one also, and I'll give you a yeah, I think we did advantages and disadvantages. Let us do examples. Okay. So here is an example. Risk factors for ischemic and intracerebral hemorrhage in 22 countries. This is called the Interstroke study or the International Stroke Study. So this was published in the Lancet in June 2010. That is Lancet. And the two of us led this study. Martin O'Donnell, he's from Ireland, and both of us, we were together in Canada at that time. And then this is an international study that we did, okay, in 22 countries. So while the study was going on itself, we got such exciting data. We wrote to the Lancet. This is the main Lancet paper. We wrote to the Lancet, and then they said, yes, it's very important international data. Halfway through the study, they told us it's important enough to publish. We will also publish your full paper later, right? So with 4,500 people, 2,500 cases and 2,000 odd controls from high-income countries, South America, China, India, and a few African countries. So totally, we had 1,926 ischemic strokes, 560 ICH or intracerebral hemorrhages, and also subarachnoid hemorrhages. So these were all the cases that we had. Okay, and these were controls, people without a stroke. And this is what we got: high income countries, South America, Southeast Asia, India, and Africa at that time. Right? We got all of this. I'll skip these data for now. And here are odds ratios. Okay, odds ratios and 99% confidence interval. Because we had such large data, we wanted not just 95%, we wanted 99% confidence interval. Okay, odds ratio for hypertension in high income countries, 2.79, right? In South America, 3.5, Southeast Asia, 4.4. So what does this odds ratio mean for hypertension? Doesn't matter which country, which region it is. What does this mean? All it means is 179% increased chance of having a stroke happens when you have hypertension compared to when there is no hypertension. So that, and it varies by different regions. Same thing with smoking. Smoking 2.68 means there is a 168% increased chance of getting a stroke if you're a smoker compared to not being a smoker. Okay, there are other ways in which to depict it. We did that in the full paper, and I'll show you this. So this was same thing in 32 countries. Totally at that time, we had 26,919 participants from 32 countries, right? We have 10,000 ischemic strokes, 3,000 intracerebral hemorrhages, and 13,000 controls. So 13,000 cases, 13,000 controls, totally 26,000, and very rich granular data that we had. So again, Western Europe, North America, Australia, Eastern Europe, Middle East, South America, China, South Asia. Then we combined India with South Asia, Southeast Asia, right? This is age and the different types of stroke, etc. Here is another way to depict odds ratios. So this is odds ratio and 99% confidence interval. This middle line is at 1, okay? Now, let us take hypertension. Hypertension, what is our odds ratio? 2.56. Where is 2.56? Drop a line. 2.56 is here, okay? This is 2.56. And this is the 99% confidence interval. It is very tight. You can hardly see the lines on either side. Here you can see the lines on either side. The lines are very short here because it is so close. 2.33 so close to 2.56 and 2.8 is so close this side to 2.56. Okay, let us take something different. Okay, which is let us take diet score, or let's take physical activity, regular physical activity, right? You have an odds ratio of 0.60, and therefore this is on the other side of the line. It is less than 1. 0.60 is less than 1. What does that mean? Satya, you want to interpret 0.60 now? Opposite of more than 1.
Yes, sir.
What does it mean? Physical activity is protective.
Less
Less
chance
than
of
1 means protective.
protective.
So there is a 40% decreased chance of getting a stroke if you exercise regularly compared to somebody who does not exercise. Got it? So that is what it means. Okay. Yeah. So that's how we interpret it as well. And yeah, this is for separately for ischemic stroke, separately for intracerebral hemorrhage also we can do. Here is again odds ratio 1, and you see these are all the point estimates. All these black boxes here are point estimates, and these lines on either side are confidence intervals. Okay, so let us take an example from urology now. Let's take prostate cancer.
One point, sir.
Yes.
Sorry to disturb you. If
No
you
problem.
go away from the central line, either
Yeah.
side, it increases the strength or decreases the strength.
Increases the strength.
Increases the strength as it goes away because
Yes.
odds ratio is more.
Yes.
Okay.
Very good. Very good question, Dr. Chandra. Okay. So all you urology specialists, any nutrients associated with prostate cancer?
High animal diet.
Animal diet. Very good. Okay. So this was done in the British Journal of Cancer in 1999. Foods and nutrients and prostate cancer in South America, Uruguay. Okay. So let's look at how they did it there. Okay. So between 1994 and 1997, they identified all histologically verified prostatic adenocarcinomas. This was the age group. Okay. And they had 190 cases. 15 patients did not, although they had the case, they were a case, they refused to participate, did not give an interview. So they had only 175 cases. Response rate of 92%, which is quite good. All right. Distribution localized 25, regional 72, and disseminated 3%. So that is how prostate cancer in these in the study was. Okay. At the same period, remember we are selecting controls. Dr. Goel, I hope you are listening now. Okay. At the same time, all patients admitted to the same hospital with conditions unrelated to any diet. And clearly they did not have prostate cancer unrelated to diet. Maybe they were admitted for, let's say, a cataract, or they had a hip surgery or something like that. Okay. And below the age of 90. Okay, so they got 240 patients, and some of them did not match to the cases, so they had 233 controls. Okay, good. So what do they have? Eye disorders, abdominal hernia, acute appendicitis, fractures and trauma, some skin disease, varicose veins, nothing related to diet. Okay, they got, because you are studying diet here. Okay, questionnaires, etc., etc. Right, these were the food consumption: red meat, white meat, processed meat. Okay, different types of organs. Okay, dairy foods, dessert, egg, grain, tubers, legumes, vegetables and fruits. All these vegetables and fruits, they collected detailed data from cases and controls. Okay, now let us see. Now, too many numbers here for you to look at. So follow my red pen. Okay. Now, firstly, and you will see this in many journals, they divided people into 4 based on how much of a particular nutrient they consume. There is a way to quantify it. So divide mean 4 means it's quartile. 3 means tertile. 5 means quintiles. Okay. When you divide people into 3, 4, or 5 respectively. Okay. So what happened to the meats? Okay. Here is red meats. Okay. Cases and controls. In quartile 1, that is the lowest amount of consumption, 32 cases and 71 controls had the lowest amount. So the odds ratio that they took, or they fixed it as 1 for them. And when they calculated for quartile 2, the next higher level, these were the numbers of people. The next higher level, odds ratio is 1.6. That means for this level of meat consumption, there was a 60% increased chance of getting prostate cancer compared to this lower level. Third quartile, 80% more. Fourth quartile, 100% more. And this is the 95% confidence interval. 95% confidence interval, 95% here, 95% here. What about white meat? This is white meat, fish and chicken, right? Odds ratio of 1 here. In quartile 2, it was actually lesser, 0.9, then 20% more, 10% more. Not statistically significant. This was statistically significant, less than 0.05. So white meat does not or is not associated with prostate cancer. Okay. Poultry, separately they looked at poultry, separately fish, also not statistically significant. Fish also not statistically significant. So any amount of fish or chicken you have, not associated with prostate cancer, but red meat is. Processed meat, even more, I think, right? Oh no, more or less the same, prostate. Okay, let's look at fruits and vegetables. Let's look, this is interesting. What do you think? I'll blank the screen for a moment. I'm blanking the screen, don't worry. What do you think fruits and vegetables do to prostate cancer? Satya, you're the only one who's active there who I can see on the video. So I'm asking you all the questions.
So fruits and vegetables are antioxidants. Obviously, they will decrease the risk of prostate cancer, maybe.
Okay. So how do we know that, Satya? How do we know that? Is it because it's antioxidant alone? Because we have data. So look at the data here. This is the data now. Look at this. Oh, sorry. Give me a second. The slides went off. I will share it again. 1 second, please. Hold on. Okay. Okay. I'm sharing the slides again. Okay. All the whatever I wrote has been erased, which is fine. So we are talking about fruits and vegetables, correct? All right. Here is fruits and vegetables. Okay. So this is quartile 1 is the lowest consumption of fruits and vegetables, odds ratio of 1. If you increase fruits and vegetables, it's 0.5 odds ratio. That means 50% reduction in chance of prostate cancer. Level 3 also 50%. Level 4 also almost 50% reduction. All right, which is wonderful. Okay. So yeah, they looked at vitamins and vitamin D and all of that. In summary, this case control study suggests an increased risk of prostate cancer with total energy, total fat, red meat, and protective effect of vegetables, fruits, vitamin C, and vitamin E intake. So that is the conclusion from a cross-sectional, from a case control study. Okay. Okay, we have another 5 or 7 minutes, isn't it, Dr. Chandra? So we can do another example of renal cell cancer and occupational exposure to trichloroethylene. Trichloroethylene is in paint industry, I think, right? So whatever. Okay. Okay. So from 1993 to June 2003, they collected from urologists and oncologists in a particular region. Okay. And yeah, controls as well. They were residents in the same geographic area, but they did not have this. They did not have bladder cancer. They did not have bladder cancer. Okay. So these are 86 cases and 316 controls, mean age of 61 and 30% women and 70% men. Tobacco smoking, right? So 40 packs and more is 19% in cases and 9% in controls. BMI, coffee consumption was there, right? So now they looked at odds ratio after matching for age and sex. Okay, odds ratio for 40 and more packs is 3.27 for renal cell cancer. Okay, same thing with obesity, a 98% increased chance of getting renal cell cancer if one is obese, and 57% more chance if you have hypertension. Okay, now what about okay, so I think this is in textile industry and certain machineries that they use trichloroethylene. Okay, so this is the cases and controls and the odds ratio. So let's look at this. Okay, solvents, oils, right? So cases, controls, odds ratio 48% more, right? With chlorinated trichloroethylene, right? With oxygenated, it was a little bit more. These other fluids that they used, again, 60% more, right? So I will skip that part. Okay, so this is the conclusion that they had. Provides new information on the association of trichloroethylene exposure and the risk of renal cell cancer. It did not reach statistical significance in some places. Okay, right. Okay, so let me now conclude so that we have some time for questions. Case control study is a robust design to determine the strength of association of risk factors with disease, right? And continuing, cohorts and RCTs, which we're going to do in the next few weeks, they are better designs to determine causation. So next week, we're going to look at what is causation. Case control design is ideal when the disease is rare, has a long latent period. I've told you this a few times. Methodology is we sample cases and controls and we measure exposures retrospectively in these people. And the odds ratio is the measure of association of the strength of this risk factor with that particular outcome. Okay, right. So I will leave you with something to think about. Okay, there are very few Indian case control studies in urology. In fact, I searched, not this year, last year I searched, I found one study, I think, right? It's a good design for student thesis. You can go beyond just a cross-sectional study that we usually do. Okay, for faculty or consultants, as an early career researcher, this is a robust design as well. A few hundred cases you collect, a few hundred controls, and we can do a superb study together. And we can explore the potential of this particular design. All right, so I will leave you with those thoughts and I will stop sharing so that we have few minutes for questions or comments from all of you.
Sir, first question, sir.
Yes.
If you take cases and when you are looking for causative factor, you should have predetermined knowledge on what factors you are doing on so many patients. You have selected 1,000. Already you should have an assumption that these things can cause. That is a primary thing, bias, where like why you have
Hold on,
taken
hold on.
carrot, why you have taken carrot, because antioxidant some effect is there. When we don't have knowledge anything about which factor has to see, how to select the so many factors in the so big robust study.
Okay. So clearly, before we launch into any research project, we need to have some basic idea about it. There must be some biological reasoning behind certain things. Okay. Therefore, one of these strategies is we want to determine the strength of association of sometimes known risk factors and emerging risk factors. We have some idea, somebody, no, there'll be some small animal studies, there'll be some tissue studies, right? So from there, we want to do human studies. Okay.
For example,
There is no bias
microbial-
over there, Dr. Chandra. What I want to tell you, there's no bias, right? You are exploring. That is not a bias. You are exploring whether carrot has got antioxidant property or not. You're exploring and you're finding out. Only when you, so if you ask the cases, tell me how many carrots you ate, tell me carefully, and then in the controls you don't ask strongly enough, that is a bias. So therefore, sometimes what they do is people who go and collect data, they need not know or they should not know too many biological details about this. You go, here is the questionnaire, you go collect. And another thing they also do to reduce bias is they don't tell the data collector who's a case and who's a control. They're all in the hospital. You don't tell them too many details. You just say go and collect. Okay.
Okay.
Yes, Dr. Rahul.
Yeah, sir, in the one of the last slides, you were showing odds ratio, and in that you were talking about 1.98 and 1.8, 80% increase in the risk of that. In that there was a figure of 3.75. So 1.98 is fine because 1 is the cutoff point we take for the odds ratio, and anything beyond it is a strong association. So how do we interpret 3.75, 2.56? How do we interpret that?
Unmute, sir.
Oh, sorry. Satyanarayana got it that time, so he can tell you. Go ahead, Satya. How will you? So 1.98 is 98% more. 1.60 is 60% more. It is 60 more than 1. What is this 2.56 and 3.98? That I don't get. Come on, Satya, you tell.
156.
Yes, sir. More association, like 200% association or 300%.
156% you should have to calculate like that.
No,
So
it was
you
1.
take, Dr. Rahul, you take it like this. Okay, give me a number more than 2. Give me any number.
3.2.
Okay, 3.20. You minus that from 1. How much is it?
2.2.
1.2.
Okay,
2.20.
220%.
200.
Okay.
That's all. Okay.
Thank you.
That means
It's a very tough. It's a very tough subject. You need to understand it very again and again. You read it only then you understand. Thank you, sir. Thank you.
Dr. Rahul, you're hearing it only for the last 1 hour, right? You got so just get the simple concepts and then you'll be able to do. Now, more importantly, let me ask this question of Dr. Rahul now. Okay, are you inspired to design a case controlled study?
Yeah, see, because we are a teaching hospital, we have the students. If we don't understand what we want to guide them, so how can we guide them? Second, you have an opportunity with a candidate for 3 years to learn from you. So it is not only for us. You add to the literature. It's not only for writing a paper. I always tell them, don't fudge the data. You go on and you will carry on the study later on also, not an issue. So we recently published. There was a PhD candidate. We were talking
Rahul, sorry. 1 second. My question was not that. My question was, are you inspired to
Yes.
design a case control design now?
Yes, I would definitely. We did one. That is what I'm saying.
Yes. So we will talk about postgraduate students and others later. Okay. Design your own study. Let the postgraduates do what they want or whatever you guide them. Design your own study as a faculty, right? ICMR is giving lots of grants. TBT is giving lots of grants. Okay, and in surgical areas, I mean, I think I told you last time or sometime, I'm sitting on 14 different government of India, different government agencies review committees. Okay, and largely cardiovascular disease, but also many other areas come into me, including Ayurveda and Siddha. We did recently. We reviewed that as well. So there is plenty of money that the government wants to do, and surgical areas, I see little, not that many, not that much of research coming forward. Okay, and recently there was a big push for maternal and child health. I was sitting on the maternal and women's reproductive research that they were doing, and or so many good proposals came, and we reviewed all of them. So my hope in doing all of this in this 1.25 hours is to give you clarity on what this design is, what it can do. More importantly, to inspire you, say, oh, I want to do this. You know what I'll be most happy with some of you writing an email to me later on and saying, I want your help to design a study. Or here, I've designed a study. What do you think about it? Or even better, come over. We have a group of people, maybe during one of your conferences on the side, before we go for a party, we'll sit down for 1 hour and we'll design a study. Okay, write a proposal and then submit it to the ICMR. In fact, in the next 2 months, I'm traveling to 3 different cities in India to conduct workshops for their institutions and close by, wherein the outcome of the workshop is groups of people come up with proposals that they're going to submit for funding. So as a society, I think you should do that as well. So what do we do with all this theory? It is very volatile. It will disappear. So put it to good use. And the best way, I learned the most when I began to teach. It took me 1 or 2 years after returning from Canada to consolidate all my knowledge, and more than that, to get the confidence to start teaching. I'm otherwise a pharmacologist, right? But to start teaching, it took me 2 years. But then once I began to teach, once I began to make my slides, read multiple books, and answer your questions, people, online or in workshops, answering questions, that's where I began to learn more.
So can I take the liberty of our Honorable Chandra Bhai to get your email address, if he doesn't mind?
Yes, sir. What is there? He is the master. He is ready to teach.
So
And
in the chat box, if he can put that in the chat box, it will be easy for us to copy that down.
I'll put it right away. I'll put it for
Thank
you.
you. Thank you, sir. Thank you, Dr. Dennis, for all the guidance. And I really congratulate Chandra to have identified the talent. He has that knack
No,
of
sir. It is
identifying.
a previous council under Surya Prakash and
Thank you.
and Arun Chawla did it. I am continuing because I could understand the importance of it and the passion, Professor Dennis Xavier. So I also thought till the end whether I understood completely or not. I want to attend, and if I attend 2-3 times, probably I will understand more.
Dr. Rahul, sorry, which institution are you from, Dr. Rahul?
Sir, I am from Medical College, Jammu.
Oh, wonderful.
It's a super specialty hospital, Medical College, Jammu.
Right. So this is the 4th year we are doing for the Urology Society.
This was first time it is being promoted so aggressively by. So when he puts a message, I thought I'll join in, because I am really into, because I am taking I won't be. I just share with you that this Sunday the MBBS students, I am taking their class for how to write a case report. So, there's a webinar on that. All the medical students in JNK, so especially Jammu division, we have 6 medical colleges, and somebody had approached me to guide them how to write about a case report. So I was just, I also wanted to listen to you also about this thing, but case report is easy to teach them. So I thought just to inspire them to write like you are inspiring us to do a case control study.
All right. Dr. Arun Chawla, any thoughts from you, please? You've heard this before, right?
I know, but again, you keep on hearing again and again. You keep on picking new points. Something new will be there, and beyond the class, the energy and the passion and the way you keep whosoever is logged in, motivated, is something which we need to appreciate and learn from you. And that was a outstanding point when you're teaching.
Right. Thank you, Dr. Arun. So that is something as now a senior person in research in urology, do consider a case control design, a multi-center case control design, in whatever common area that you're thinking about. That would be good. So Dr. Ginnell, welcome back.
Hi, sir.
Back from your OT, you were in
Yeah,
OT,
yeah,
you
yeah.
said.
Yes, it's done.
Yeah, so we're just kind of concluding the session. Any thoughts from you, Dr. Ginnell?
No, sir, this is third time we are with you, and every time I'm actually learning new things, and I understand that it's very difficult to retain everything. But actually, what has happened is this time we submitted 5 proposals for ICMR. It may not be good, but thing is, we started writing proposals, and that itself, I understand that this is a good experience. So probably we'll improve the quality and we'll get a grant next time.
Dr. Danish, we need to have expert comments from Dr. Apul also. He's waiting.
Yes, I don't see him. Dr. Apul, yeah, he's here. Dr. Apul,
Yeah,
any thoughts?
I was there throughout. So thank you, Dr. Xavier. You clarified so many things today. And as I said, I had said yesterday also, cross-sectional studies and case control studies, I think, are the most important study design that postgraduates and early researchers, I think, they do. Because doing a randomized control trial, especially in surgical specialties, is difficult. So there are definitely there are certain drugs in urology, but we do randomized control trials, but mostly we fall back on cross-sectional studies and the case control studies. So so many things were clarified. I really enjoyed your presentation, and thank you, ASU, Dr. Chandramohan, Dr. Arun Chavla, everyone. Thank you so much.
Thank you, sir. Thank you very much. So unmute,
Okay.
sir.
Right, sorry. Okay. All right, we'll say goodbye now and enjoy the weekend, and we will catch up next, not Thursday. Thursday is May 1st. We are meeting on May 2nd next.
Second, yeah,
correct?
Friday, yeah.
And we are doing, I think, cohort studies at that time.
Absolutely,
And at that time, yeah, we're going to look at causation, Hill's criteria for causation, right? And all of these concepts, and as many of you said, I'm going very slow and in a very gentle way. I'll explain, and only what is relevant. There are lots of other complexities, but I've distilled it down to really simple things. And then we'll again see examples. At the end of it, what would be really good is if you all get inspired to design urology or address urology questions using these designs, it would be fantastic. Okay. Goodbye.
Okay, sir. Thank you, sir. Thank you.
Thank you very much. Thank you, everyone.
Thank you. Thank you.
Thank you,
Thank
Apul
you.
sir. Thank you, Ginil.